dear participants, respected national and international delegates, welcome to BIMSSCON Virtual 2020 Congress, organized by International Federation of Medical Student Association of Bangladesh. I'm really delighted of having such an opportunity to deliver my presentation regarding cutting-edge technology in clinical oncology. I'm Dr. Mohammad Kamruzzaman Rumman. Uh, mm, I am working as assistant professor in the Department of Radiation Oncology at National Cancer Institute and Research Hospital, Mohakali, Dhaka. I got my MBBS degree in 2003, then FCPS in clinical oncology or radiotherapy in 2011. Finally, I got my MD in radiation oncology in 2017. I have opportunity to take lots of training from abroad. I'm interested in molecular oncology, so I took several training, short-term and long-term training in molecular oncology from United Kingdom and also from Medical University of Vienna. Now I am going to start my topics. What do we mean by clinical oncology? Clinical oncology relates to any type of cancer treatment that is not surgery, including radiotherapy and systemic therapy. What are the branches of the clinical oncology? Clinical oncology includes the management of the patient in total, except surgery. So the major branches are radiation oncology, then medical oncology. Clinical hemato-oncology also included in the medical oncology, and other branches are molecular oncology, imaging oncology, immuno-oncology. As I am clinical and radiation oncology, I will focus on radiation oncology, molecular oncology, and some part of imaging oncology. Now, radiation oncology. The branch of science that deals with the radiation therapy is called radiation oncology. What do we mean by radiation therapy? Treatment of cancer, and in some cases, some benign conditions, when treated by ionizing radiation, is known as radiation therapy. Here, actually, ionizing radiation is our concern. Radiation may be non-ionizing, that have very little impact on the medicine. So, actually, we are focusing on ionizing radiation whenever we want to give radiotherapy. The physicians who are expert in radiotherapy are known as radiation oncologists. Approximately 70% of the cancer patients need radiation therapy for their treatment. So it is very important part of the cancer patient management. The aim of radiation therapy is to deliver maximum dose to the tumor volume as well as minimum dose to the surrounding healthy tissue. Final goal, ultimately, eradication of tumor, prolongation of survival, palliation of the symptoms due to cancer, and improvement of quality of life. First goal, actually, we want to eradication of the tumor along with improvement of the survival. That means as a definitive treatment. And last two, for palliation of the symptoms and improvement of the quality of life, for treating the cancer patient where there is no hope for cure of the disease, just only several weeks to several months survival, and we want to give good quality of life. Some volumetric concept is necessary for clear understanding of the mechanism of action of radiotherapy. In clinical practice, whenever the patient is suffering from cancer, especially in solid tumor or solid cancer, whatever we find clinically or we watch in the radiologically, the tumor inside the body is gross tumor volume. This gross tumor volume is our prime target for radiotherapy. If we want to, in the picture that is centrally placed, give radiation to the gross tumor volume only, so it is not possible for eradication of the tumor, because we know that any tumor, uh, there is chance of microscopic spreading. So to cover the microscopic spreading, we need another margin, that is clinical target volume. If we focus on clinical target volume, okay, it might cover the tumor, but there is chance of also missing some part, because there is always continuous movement of the organ inside the body, and there is some uncertainties due to day-to-day setup, as usually we give radiation for few days to few weeks to uh, 1 or 2 months. So daily setup is necessary. In there is chance of some uncertainty. To cover this type of uncertainty, we need additional margin known as the planning target volume. These three volumes are mandatory for actually targeting tumor by radiation therapy. We need some understanding of organoleptic volume, because whenever we want to give radiation to the planning target volume, there is chance of some radiation to the normal structure or normal organ of the body. This normal structure or organ is known as the risk volume. We want to give maximum volume to the tumor volume and minimum dose to the surrounding normal tissue. Now the mechanism of radiation therapy. Radiation acts into the body by direct and indirect effect. It is interesting that radiation only directly affects inside the body in case of 20 to 3%, because actually we want the mechanism of action radiotherapy for indirect effect. I will discuss just into the next slide. First, the direct effect means direct breakage of the double-stranded DNA, as because DNA is the prime target of radiation. DNA is a double-stranded structure, and if this double strand is directly breakage by radiation, is known as the direct effect. If radiation damages the only single breakage, usually the single break repair very quickly, so damage is not possible. Now the indirect effect. What do we mean by the indirect effect? Indirect effect means first, radiation is not directly acting on the DNA. First, it reacts with water molecule, because we know that human body mostly composed of water. So radiation directly interact with the water molecule, then liberation of some free radicals. These free radicals have very few lifespan, so they uh, uh, interact then with DNA, and breakage of the DNA occur like the chain reactions. So this type of effect lasts long, and we want to harness this type of mechanism of action in our commonly radiation machines. X-ray and gamma rays are mostly indirectly ionizing, what we used in most of the countries in the world. Also, now the development of newer technologies, some machines like the proton therapy or carbon ion therapy, we can utilize the direct effect of the radiation. What are the techniques of modern radiotherapy? First, external beam radiotherapy, then brachytherapy, intraoperative radiotherapy, radioisotope therapy, radioimmunotherapy. I will discuss shortly later on. First, the external beam radiotherapy may be photon beam therapy, electron beam therapy, proton beam therapy, or neutron beam therapy. And the latest addition is carbon ion therapy. What do we mean by the external beam radiotherapy? When ionizing radiation given from the distant side, usually certain distance outside from the skin, is known as external beam radiotherapy. There are several modes of external beam radiotherapy, like conventional radiotherapy, three-dimensional conformal radiotherapy, IMRT, that means intensity modulated radiotherapy, IGRT, image guided radiotherapy, rapid art therapy, stereotactic body radiotherapy, stereotactic radiosurgery, and also other types of radiotherapy is possible. Now I will discuss shortly about the technique. Conventional radiotherapy means whenever radiotherapy planning is done manually only by surface marking over the skin. And 3D conformal radiotherapy means this is the computer-aided three-dimensional conformal radiotherapy where beam intensity remains same, beam angles are fixed. Only we can give the radiation by three-dimensional technique. And the next version is the intensity modulated radiotherapy or IMRT. That means where beam intensity can be modified, but usually takes prolonged time. Beam angles are fixed. In image guided radiotherapy or IGRT, the radiotherapy can be modified according to the organ movement. But this type of radiation therapy, as I have discussed, are a little bit prolonged time. So now the new version of rapid art. Here, radiation can be given from any angle and within very short time in an arc manner or circular manner. You might have known about SRS or SBRT. SRS means stereotactic radiosurgery. Although this is termed as surgery, actually it is not the surgery. It is the technique, especially in case of the small intracranial tumor, where single session radiotherapy is given in a circular fashion, and it includes special stereotactic frame. Outside the brain, whenever we give stereotactic radiotherapy is known as stereotactic body radiotherapy. Here also we give in the circular fashion and deep-seated tumor. There is a latest edition of radiation therapy, that is the tomotherapy. Tomotherapy means just machine, radiotherapy machine is just like CT scanner. And IMRT can be given very precisely using real-time CT images of the tumor. That means from the beginning, the radiation field may be larger, and after day by day, whenever tumor is a small shape and size, then the shape of the radiation also may be small according to the shape of the tumor also. So that the patient will get very precise radiotherapy and normal structures will be more spared. There are also other modalities of treatment like the robotic arm radiosurgery. I have already I will show you in the later. Now I will show you very shortly about the historical point of view of radiation therapy. First, Grange ray machine was discovered after discovery of the X-ray, as we already know that Wilhelm von Röntgen already discovered X-ray in 1986, and he got Nobel Prize for this later on. Then actually, first it was for only radiology purpose, but after a few years, the new version of the X-ray machine converted to Grange ray machine. I have shown it, very old version. Then actually, orthovoltage radiotherapy machine was built. These two types of machines was used for giving radiotherapy only superficial tumor. Deep-seated tumor could not be treated by this type of machine. Then there was some development in the radiation machine. Uh, First, their cobalt machine was uh, built, then development of Linux machine. We can see there is a very older version of the cobalt machine in the France. First, in the left hand side and in the right hand side, the little cute uh, baby uh, was in the very Linux machine in the one of the London hospitals. Then actually some evolution happened in the development of the radiation therapy. Now we can see the modern cobalt and also modern Linux machine. Uh, in the developing country or middle income country, there are lots of cobalt, but in the developed country, actually mostly are the Linux. The main difference between the cobalt and Linux is that radiation in the cobalt, the main source of radiation is the radioactive sources, cobalt 60. So there is always chance of continuous emission of radiations from the cobalt sources, as it contains the radioactive sources. So very much precise and huge instrumentation is necessary for radiation protection. So Linux machines, that means the linear accelerators was developed to overcome this limitation. That means it is simply a X-ray machine, newer version of the X-ray machine, where radiation is produced by X-ray techniques, and also we can give the superficial tumor without emission of the X-ray, only from the electron beam. The basic concept is that the radiation first high voltage of electron comes out from the machines, then whenever it targets the tungsten, then X-ray is produced. And these two type of radiation is harnessed in the modern Linux machine. Rapid Arc machine is the one of the latest versions of the Linux machine. Then I have already mentioned that image guided radiotherapy. That means the machine can give radiation according to the movement of the organ. As for example, huge movement of the lungs, continuous movement, and radiation can be given into the lung tumor by respecting the lung organ. And also we can give radiation to the abdomen by respecting the visceral movement also by IGRT technique. These two types of machines are very latest version, CyberKnife and tomotherapy. These two type of machines are not available in our country, but available in some developed countries. By CyberKnife, usually we give the stereotactic radiosurgery, and other modalities of treatment also can be possible. By tomotherapy, actually, we can give radiation by utilizing the technique of CT scan. Actually, tomotherapy machine consists of radiation sources, and it purpose the dual. That means simultaneously it can give radiation, and simultaneously it continuously take the CT images, so that actually it can be delivered according to the shrinkage of the tumor, and last few days of the radiation, whenever tumor size is very small, field size of the radiations become very small, then minimum dose to the normal structures can be possible. So sparing of the normal structure or organ at risk can be possible in case of the tomotherapy. I want to give some tips on proton beam therapy. This is the latest versions in the field of the radiation oncology. We have no proton therapy at now in Bangladesh, but proton therapy machine are also available all over the world. In the developed country, now proton many proton beam therapy are being installed. It has few advantages than the modern lineup. Main advantage is that whenever we want to give the deep-seated tumor, then actually proton beam is very much useful than the conventional lineup machine. Here, deep-seated tumor can easily be destroyed without any impairment or any harmful effect to the surrounding normal tissues. So, if we consider what we have achievement from past to current state, there in the first picture, I have shown that the man with neck cancer receiving radiotherapy treatment from a radium bomb designed in the Belgium in 1925. The patient was very much feared uh, because he thought that actually there burst of the bomb and he may be hurt or maybe died. But uh, in our current facility, the woman with skin cancer in the scalp receiving electron beam radiotherapy without any fear, and she is enjoying the most of the radiation by the modern true beam LINAC machine. True beam LINAC machine are also available in our country. Now, I will give some idea of brachytherapy. What do we mean brachytherapy? This term is not popular among the physicians who do not practice oncology, and also the newer doctors or medical students. So I want to focus some point regarding brachytherapy. What do we mean by brachytherapy? Brachytherapy means whenever actually radiation given by sealed radioactive sources from short distance, that means very close to the tumor, this type of treatment is known as brachytherapy. Commonly used sources are iridium-192, cobalt-60, and cesium-137. Brachytherapy may be high dose rate brachytherapy, medium dose rate brachytherapy, low dose rate brachytherapy, and pulse dose rate brachytherapy. That means within very short time, we can give very small to very high dose to the tumor. There are some techniques of brachytherapy. We can give surface brachytherapy. We can give inside the tumor still radioactive sources by interstitial brachytherapy. Inside the body, there are some luminal structures like esophagus, trachea. So we can give intraluminal brachytherapy. And there are some cavitary structures like vagina, cervix, endometrium. We can easily give intracavitary brachytherapy. The common machine used in brachytherapy is the high dose rate brachytherapy, and that consists of steel radioactive sources iridium-192. There are lots of applicators for different types of brachytherapy for treating different types of cancer. I have shown here only the most common Fletcher suit applicator for carcinoma cervix and endometrium. In our country, we usually give the cervix and endometrial brachytherapy. So I have shown here only the Fletcher suit applicator. Here we can see that the patient in the first picture, the patient is getting the esophageal brachytherapy. This is the real-time images, and in the second picture, this is the diagonal view where the patient is getting the intraluminal brachytherapy to the carcinoma esophagus. Now the intercavitary brachytherapy to cervix. First view is the diagonal view. We can see that along the central uterine canal, there is a central tandem, and on the both sides, there are two ovaries. So this type of brachytherapy, we can easily eradicate the tumor along with external beam radiotherapy. In the right-hand side, there is the 3D image of the carcinoma cervix brachytherapy. We can easily see or observe that the brachytherapy instrument are actually placed or not. This is also the diagonal view of the intercavitary brachytherapy to cervix, and in the right hand side, the real-time images. These images is actually is from my experience images. I have performed lots of brachytherapy at National Cancer Institute. This slide is one of them. Now, what is the interstitial brachytherapy? Here I have shown the interstitial brachytherapy to breast. Brachytherapy needle insertion usually placed inside the tumor by some catheter through template. This is the interstitial brachytherapy. There is basic difference between interstitial and pre-operative or par-operative brachytherapy, which I will show you later. Brachytherapy catheter, we can see the second picture, brachytherapy catheter in situ for carcinoma of the breast. Just there is placement of the catheter inside the breast, but no operative scar marks or opening of the skin or surgery is not required here. One of the latest versions of brachytherapy is interstitial brachytherapy to prostate. This is a very sophisticated treatment technique, needs a special center for interstitial brachytherapy to prostate because there is improvement of the survival of the prostate cancer. As so, there is huge development of the interstitial brachytherapy. First picture, the operative procedure of the interstitial brachytherapy, that is transrectal ultrasound guided, and also I have shown the pictorial view of the transguided needle insertion techniques in the prostate brachytherapy, how the needle is inserted through the template to the prostate. In some countries, especially in the developed countries, there is robotic aided prostate brachytherapy facility available. That means first picture, I have shown that there are multiple channels for carcinoma of prostate, and this is given by the robotic arm or robotic assisted prostate interstitial catheter. This is an example of the surface brachytherapy. Actually, this type of brachytherapy still now are not available in our country. I have shown it in the United Kingdom. This technique is very popular in the Europe and United Kingdom. We actually give the surface radiations by electron beam. That is absolutely total non-surgical and no intervention is necessary, but actually surface brachytherapy response rate is excellent. So in Europe, this is very popular. We can see that squamous cell carcinoma of external auditory canal is treated by the high dose rate brachytherapy applicator over the periauricular area. What do we mean by the intraoperative radiotherapy? I have already shown the interstitial brachytherapy. That is the mini operative procedure, but intraoperative radiotherapy means it's a part of the operation. Here, a good team with anesthesiologist, radiation oncologist, and surgeon, very much essential part. It constitutes delivery of the radiations to the tumor bed while the area is exposed during surgery. So surgeon has to expose the surgical bed, then the radiation oncologist should give the radiation during the operation period. Commonly used cancer is carcinoma breast, stomach cancer, rectal cancer, and other lots of cancer. This is the pictorial view of the intraoperative radiotherapy to breast. First, the field exposure by surgeons, then template and catheter are placed for intraoperative brachytherapy to the breast. As there is continuously evolving in the radiation oncology, we want to locate the tumor. So oncology imaging is playing a central part for the treatment decision, also deliberation of the treatment. The conventional imaging protocols are ultrasonogram, X-ray, mammogram, nuclear bone scan, CT scan, MRI. There are some addition of the imaging oncology, like the PET CT scan, flexible PET, or PET MRI. I will just briefly discuss on regarding oncology imaging. In radiotherapy planning, two machine is used. One is conventional simulator, another is CT simulator. You might have known about the simulator. What do we mean by simulator? Actually, in radiation machine, there is chance of extra radiation exposure. So always we want to give minimum exposure of the patient or attendant. So actually, in the simulator, what we do? We do some surface marking, and we also fix some points how the radiation can be given to the patient. So we can change our plan also, so that the best possible techniques of radiotherapy can be evaluated. This type of evaluation is done in the simulation. So simulation is a requirement for the actually patient dimension for those calculation, or identify some reference point, so that the patient can be mm, delivered the actual radiation therapy with minimum error. CT simulator is the essential part of the modern radiotherapy. We actually localize the actual tumor inside the body and how far it from the skin surface. Actually, this is a diagnostic CT scanner with some addition like the laser alignment system and 3D imaging workstation, whiteboard, and flat tabletop. In the CT scan, conventionally there is very small board and just couch. The tabletop is curved, but in the CT simulator, the tabletop is flat, just like the radiotherapy machine. It simulates with the radiotherapy machine, so that we can actually plan the total radiation therapy, like the modern techniques of radiation therapy, 3D CRT or IMRT, with better treatment planning system. Nowadays, most of you have already habituated with PET scan. PET scan is the technique which combines a proton positron emission tomotherapy scanner and computed tomotherapy. That means it consists of PET and CT. So the combined is known as PET CT. PET can use the one radio tracer injection, that means radioisotope, intravenously given. Commonly used radio tracer is 18-FDP, that means fluorodeoxyglucose. Typically, it takes about 30 to 60 minutes to travel through the body. Total scanning time is usually about 30 minutes. So total PET scan time, approximately we need 30 to 40 minutes. Actually, this type of radio tracer mainly taken by the tissue who actually takes the glucose very rapidly. That means the tumor tissue or rapidly metabolizing tissue usually takes the glucose at very high level. So in the most of the cases where the metabolic rate is very high, the radio tracer uptake is concentration is very high. By utilizing these type of techniques, we can usually localize the very small tumor inside the body. So role of PET scan in oncology are numerous. Some of them I have included, that we can detect the cancer at very early stage. Also, we can detect the metastasis in the very early stage, where the cancer might be metastasized, which is not possible to assume by clinically. We can assess the effective of the treatment. That means before the treatment, we can do a PET CT scan. After the treatment, we can do PET scan, so we can compare how much effect occur, tumor shrinkage or metastatic focus already damaged or not by the treatment. We can determine whether the cancer has returned after completion of the treatment. That means after a prolonged time or a given period of time, whether there is any relapse or recurrence of the tumor. By the PET-CT scans from the very beginning, we can also determine the prognosis of the disease also, whether the disease might be curable or not. In this slide, first slide, the machine is the next generation PET-CT scan. In the same facility room, two actually scanners are fused to form very high contrast imaging, and this type of new generation PET-CT scan, the soft tissue resolution is very much better than previous version. And in the second slide, I have shown that the 3-image reconstruction in the PET-CT very easily the tumor can be localized. One of the limitation of the PET-CT scan is that soft tissue resolution is relatively less than the MRI scan. So flexible PET scan can minimize these types of limitations. There is also development of PET MRI also, where the PET scanner MRI is fused so that the soft tissue resolution might be maximum. And this type of machine is now only a very few machine is available in America and some countries in the Europe. Hopefully, this facility will be available in other countries also. I have some experience in molecular oncology. I'm too much interested for the development of molecular oncology, and I want to utilize this type of techniques in our country for development of precision medicine so that the patient can be treated from the very beginning with the clear insight of the tumor. What do we mean by the molecular oncology? Molecular oncology is the study of genes that are involved in the development of cancer, that includes the diverse techniques ranging from genomics, computational biology, tumor imaging in vitro and in vivo functional models to study biological and clinical phenotype of cancer. So molecular oncology includes, in short, the cancer cell biology, translational radiobiology, molecular radiology, pharmacogenomics, precision medicine, cancer informatics. It has also numerous subdivisions, which I have not mentioned. Just in a nutshell, cancer biology and informatics mainly focus on 4 things: genome profiling, proteomics, transcriptomics, epigenetics. That means initially it was thought that only genome profiling may be a solution for the treatment of the cancer. But later, the concept of the proteomics, that means if we can know the information from the protein levels or know the information from the transcriptome levels, transcriptions level, or some epigenetics level, that means cancer cells may proliferate without genomic alteration. Only methylation or hypomethylation and hypermethylation have role for the development of the tumorigenesis. So epigenetics information also may be helpful. By harnessing this type of molecular technique, actually we can develop the personalized therapy for individual cancer treatment. Commonly, molecular techniques, some of the things already you might have known, cytogenetics and karyotype typing. By this type of techniques, we can know the number or any structural abnormalities of the chromosome, and hybridizations like the fluorescent in situ hybridizations, comparative genomic hybridizations are so much helpful procedures for molecular biology inside the tumor. And also we can use some blotting techniques like the northern, southern, and western blotting techniques. You are almost familiar with the PCR, that means polymerase chain reaction, and there are lots of techniques of the PCR, among them reverse transcriptase PCR and real-time PCR, that means the qPCR, are very much popular. Sometimes single nucleotide polymorphism or copy number variations are measured inside the tumor cells for genome profiling. This might give an excellent idea about the tumor biology. Now, the sequencing of DNA is a in-need technology. That means initially we sequence the DNA by Sanger sequencing, then development of the pyro sequencing, and latest edition is the next generation sequencing, that is NGS. I have some experience in the next generation sequencing. I will share a few slides about that. If we want to know the RNA and RNA sequence, or just messenger RNA level or microRNA level, we need some array technique, that means the microRNA techniques for RNA analysis. Actually, sometimes the model system is very much necessary for gene knockdown and knocked-in systems, because if we want to see a drug, how it acts inside the human body at molecular level, before experimenting into the human body, we need mice lab for introduction these types of medicine, whether it will create so much toxicity or not. So creating model systems is very much helpful for development of some drug policy. Now I will very shortly just enumerate some molecular technique. I have shown here southern blotting technique. We usually analyze the DNA by southern blot. We analyze the RNA by northern blot, and also actually we analyze the protein by western blot. By hybridizations, actually a hybrid means the fusion. As the DNA is, we know that the DNA is composed of two complementary strands. So if there is any mutation, if there is any deletion, if there is any fusions at the genetic level, we can assess this by the hybridization techniques. Of them, the fluorescent immunohybridizations are most popular, and I have shown here the hybridization techniques, fish mesh, fluorescent machine, and the first slides show the Philadelphia chromosome in the nucleus of the leukemic cells by fish technique. In the COVID era, PCR technique is very much known. That means the reverse transcriptase PCR. We can analyze very few genes or a number of genes by the PCR, but whenever we need huge number of genes in a single settings, in a single time, then actually sometimes it is not possible by the conventional PCR. So we need the next generation sequencer. Actually, this sequencer consists of the total IT based systems where the bioinformatics knowledge is very much necessary. I have already talked about microarray. In the microarray, very much complex system, but in shortly, I have shown the steps required in the microarray experiment. Here, actually some RNA was extracted and microRNA level were experimented from the laryngeal cancer by microarray technique. Now, some discussion about gene knocked out and knocked in. What is knocked out and what is knocked in? Why it is necessary? That means we know that we have for the development of the tumor or tumorigenesis, mainly oncogene may act as the driver for development of the tumor, and tumor suppressor gene. That means deficiency of the tumor suppressor gene. Actually, whose main function is to prevent the tumor. Whenever there is deficiency, then there is development of the tumor. So we can experiment the mice by gene knocked out and knocked in to see some oncogenes or tumor suppressor gene activity by this technique. The latest addition is the actually gene editing mechanism CRISPR. CRISPR technology is a simple but powerful tool for editing of the genome level. Initially, DNA recombinant technology was very much popular, but actually that combined with the conventional PCR method, it took prolonged time, and there are lots of limitation of the conventional PCR or recombinant DNA technology. So if we want to addition of the gene at the molecular level, CRISPR technology is the cutting edge technology for this genome edition. That means it is a homing divide. One part is CRISPR, another part is Cas9 enzymes, and combine this, we can cut the DNA at the genome level and edit its sequence as we want. Two well-known scientists, Emmanuel Carpentier and Jennifer Doudna, they developed the CRISPR techniques in 2012, and after that they were awarded so much. In this year, the Royal Swedish Academy awarded the 2020 Nobel Prize in the 7th October in chemistry to these two scientists for their excellent method of gene editing, CRISPR. And also $1 million Kavli Prize in 2018 were awarded to these two scientists along with Virginia Sickness for their invention of CRISPR and Cas9 technology. This is a precise nanotool for the gene editing and revolution in the oncology and other biological sciences. I have some experience sharing. First, I have shown here that in 2013, I took my higher training in clinical and radiation oncology at Hinduja Hospital, Mumbai. I have exciting experience in the Royal College of Radiology, where I attended the conference in 2013 in the London at the Barbican, where there was development of the functional imaging radiotherapy. Now, what we see in the functional MRI or functional PET, that means that was first declared in this conference. In October 2018, I have excellent experience in the Applied and Translational Radiobiology Lab, Medical University of Vienna, Austria. Here I work with a research group that are engaged in very much experimental model, and they were engaged in the development of some models so that effect of the radiations can be observed through these models without harming the normal tissue. First pictures is in the DNA sequencing lab, and second pictures is in the cell culture lab. These features is very much interesting because I was so much lucky that they allowed me to their mice irradiation lab, very much sophisticated, and normal person is never allowed in this type of mice lab. First person is the Mr. Jacobs. He is an excellent researcher for observing the pelvic toxicities, in case, especially in the bladder toxicities, whenever we give the radiations to the pelvis. And in the second slide, there was different mice group experiment. Actually, I have observed that how they maintain this type of quality of research in their lab. Here I have shown that how they actually perform the research work by the mice model. One interesting feature is that the mice is very much educated. That means Mr. Jacob will just introduce a catheter, and actually the mice allowed it. That is very funny. And stem cell and cell culture in biology at Pune, India, in May 2019. First slide, actually, I was doing the cell culture from the human cancer cell line, from the leukemic cells, and later on the renal cancer cells. And in the second slide, actually, I had some training in the polymerase chain reaction. Now I am doing a research work in collaboration with North-South University for development of precision medicine in colorectal cancer by next generation sequencer for actually personalized therapy for colorectal cancer patients. That would be the very low costing. So I want to start the cost-effective technique. And first slide, actually, I am preparing and slicing the FFPE tissue block by microtome. I'm slicing by slice by slice. I'm cutting the tissue, this type of microtome for DNA extractions, according to the actually protocol. And finally, DNA extractions. Actually, we are completing the DNA extractions by protocol at the North-South Genome Research Institute Molecular Lab. So, just in a short, my research work in oncology, that means these three researchers' fundamental research work. But I have completed my MD thesis research for actually development of the technique. That means that was the actually single channel versus multiple channel of the Miami applicator. And for your kind information, this Miami applicator actually was not available in our country. And luckily, I found in my institute, nobody were aware of this type of sophisticated instrument. And I wonder, then actually I developed my protocol. Finally, I have completed my research work by this type of sophisticated instrument, that is computer-based 3D technique in case of the vaginal brachytherapy. And finally, I succeeded, and actually it worked very well in excellent manner. I have completed my dissertation for the short-term response of radiotherapy on secondary brain tumors. As we have very much brain tumors in our country, that means not primary, that develop from the another sites, and actually the survival of this type of patient is too short. So actually, I observed the short-term response of radiation therapy. My ongoing research, collaborative research with the North-South University. This research is funded and approved by the Planning Ministry of Bangladesh at North-South Genome Research Institute from September 2019. Still, it is going on. That is characterizations of the molecular heterogeneity of the colorectal cancer by targeted genome sequencing with a goal to develop cost-effective precision medicine at individual level and explorations of the metagenomics for searching associations between microbiota and colorectal cancer by next generation sequencing. I hope that if I can complete this type of molecular research in my country, it might be a milestone for future numerous research in the field of molecular oncology. And I also hope that in near future, we can develop some molecular techniques that is very much cost effective. And from the very beginning, we can assess the prognosis of the patient. So the total cost may be very low for the cure of the patient. So take home message. Clinical oncology is vast and ever changing. We need to be technophile and adapt to its current state of art technology for clinical decision making in era of genomic revolution. That means sequencing of human genome and development in high throughput technologies. That means that heralds excellent futures for personalized therapy for cancer patients. So last of all, harnessing molecular technology might be future directions for innovative approach for treating cancer patients at individual level. Thank you very much for patient hearing. Welcome to the hands-on training program for the treatment of the cancer patient systems. First of all, we have to take some images for well localizations of the tumor inside the body. So we are ensuring the patient should come first here, and she should take some positions, and in the CT scan or the conventional simulator systems, this room is dedicated for CT scanning with some simulator facilities. This machine is especially dedicated for CT scan of the patient with CT simulation. Here first, we have to ensure the positions of the patients with various immobilization device. This immobilization is necessary for accuracy of the treatment process. If we can take the images in the right positions, then actually we can implement the total treatment systems very accurately. First, we have to take the permissions of the patients. As for examples, I am seeking permissions from the patients. আমরা আপনার এখন কিছু ছবি নেব, আপনার কোনো আপত্তি নাই তো, আর আপনি কোনো ব্যথা পাবেন না, আপনি কোনো ভয় পাবেন না। So I have taken the permission of the patient, and also we have to ensure the privacy of the patient also. Now we will take some images from the machines.
So we use here a thermoplastic mask. So that mask is used according to the body shape of this patient. It is customized made. Okay. So one mask for one patient. It is very individual, so that the patient cannot tilted and the patient cannot move during the treatment. Okay. So we have to ensure this. So for this we have a very expert radiographer here, Mr. Sarwar. So you will do all the things. We are also here. So you can say something for how you set up this. So it's nothing, it's like a CT scan, but we have to add some emulsion devices for this. So that is as mimicry of the final treatment. Okay.
We'll follow shoulder position also. We'll follow which one is straight forward or not, and we'll align with the laser. We can follow axial laser here. This is the point.
Actually, the more we spend time here, the treatment precision is far better. Okay. The first step to beginning a treatment, radiation treatment.
To follow also out of contrast, both contrast. Here. For align the
switch off the light.
It's very helpful to minimize the tilting of head.
Boom light. Another one. Okay.
And
switch off.
We'll follow some another anatomical marking, because
now you see the laser alignment, the red light. Okay. This red is three-dimensional, transversely and sagittally.
This is a immobilization device which is necessary for patient immobilization, so that patient cannot move during image taking and also during the radiation treatment. So we can give the accurate radiation, and this immobilization device is known as the thermoplastic mask. Now it is hard, very hard, but we have to melt. Melt it with hot water. Then it will actually take the shape of the patient. Okay.
So this is a hot water bath. So we have to sink this mask to the water.
We'll wait for 1 or 2 minutes.
If we give more temperature, then this thermoplastic mask is not used for the treatment purpose. And if we make it very less, then it will be hard. that is not also not suitable for the making of this thermoplastic device.
You can see it's becoming
So now
transparent.
Yeah. So
when
it was like a
become
white.
totally
Now it is very transparent.
It's perfect for neutralize the patient. We should go there.
Yeah. So before making this, we have to inform the patient this thermoplastic mask. আচ্ছা, আমরা আপনার এখানে একটা থার্মোপ্লাস্টিক মাস্ক, এটা মুখোশ পরানো হবে আপনার এখানে। এটা সামান্য গরম থাকবে, তবে এটা খুবই তাড়াতাড়ি নর্মাল হয়ে যাবে। কিন্তু যখন আমরা আপনার এই থার্মোপ্লাস্টিক মাস্কটা বানাবো মুখোশ, তখন কিন্তু নড়াচড়া করা যাবে না। হ্যাঁ, নড়লে আপনার যেখানে ট্রিটমেন্ট পাওয়ার কথা সেটা আমরা ঠিকভাবে মানে পাবো না। কোনো কিছু নাই,
আমি আপনাকে অ্যাসিওর করতেছি আপনি খুব বেশি ব্যথা পাবেন না। একটু গরম লাগবে, হঠাৎ করে মনে হবে বেশি গরম, 1 মিনিটে ঠান্ডা হয়ে যাবে। হ্যাঁ, আপনি একটু সহ্য করবেন, আপনার চিকিৎসাটা ভালো হবে। হ্যাঁ, একটু সহ্য করবেন। মাথাটা নরম করেন, মাথাটা আর নাড়াবেন না। হ্যাঁ, একটু উঁচু করেন, হালকা উঁচু। হ্যাঁ, ওকে
ওকে, কাম। ডোন্ট টক, মানে কোনো কথা বলা যাবে না।
চোখ বন্ধ করে রাখেন। হ্যাঁ, চোখ বন্ধ করে রাখেন।
No pain.
Now we are applying the thermoplastic mask. It will take the shape of the patient. Now it is first it was very hard, but now it is very soft and it will take the
You
shape
see
of the
now,
patient.
we are making. So we have to fix this. We use our hand. You have to very expertise for this session, because if you not fix according to the shape, then it will make chance to radiation deliver somewhere else. So you see this treatment is going to be delivered in this area, I mean face area, but we have to also fix this shoulder region, the mid chest, because it is the quality assurance for treatment.
Okay.
There is a
maintain
very
for
important
every
thing also.
patient.
During immobilization the patient, we should very carefully follow the patient alignment. Very carefully. It can be tilted.
So
That's so interesting.
So yeah, after making this, we will show you only the mask without this patient. This mask according to this patient.
Okay.
And we have to register his name, age, and especially ID number. So there is no chance to mix up this patient for other patients.
So finally, the thermoplastic mask, what we have applied this, it has taken the shape according to the shape of the body of the patient. Okay, clear?
Now we'll wait for about 15 minutes.
15.
Minimum 15 minutes to become it normal time.
Okay. Along with this type of face mask, we can use also this mask includes the shoulder, but if we want to treat the brain, then actual brain tumor, then we have to use the short thermoplastic mask. This is dedicated for only brain. We have different immobilization device systems for this immobilization device system is dedicated for breast. We have also another immobilization device. This is the breast. This is the breast board. This the patient should lie up on this breast board, and arm should be both sides of the body, so that we can immobilize the patient with breast tumor, and we can treat onwards. We have different type of immobilization device for different tumors in the different parts of the body.
So this laser is meet this point. So there are 3 points here. One is here, and then is longitudinal, and another is there. Okay. So these 3 region we have to mark in a lead marker. Okay. So you see is the marker. So it will place within this meeting region. Na? So this marker will show in an image when after taking the images. Okay. So now we are going to take image. Our plan to cover this area to this area. So we do not need the whole body scan, only this interest area, because it is also very low radiation, but it is also very harmful for the radiation in our body.
Setup of the immobilization device. Now we can see the image acquisitions by the monitor systems. We have to take the CT scan image and actually we can see that how the image is converted or image is taken. Here sometimes we have to inject the radio-opaque dye intravenously.
We took a topogram.
Okay. Now this is a topographic images from the
lateral image.
Lateral view.
Now
Our
we will see the interested area.
Okay. After taking the all image, this is the 2D image. So we have to convert this 2D image into the 3D, because the tumor inside the body is the 3D system. So we have to reconstruct the image also into the 3D form, and this is not possible here. So we have to transfer this data images to the radiation treatment planning system. After CT scan and CT simulation, the image should be transferred to the treatment planning system. In the treatment planning system, actually for Vitual, which we usually plan the total treatment system, and actually the electronic images which are shifted to these treatment planning systems, we convert to these treatment planning systems into the 3D systems, and actually we animate the total images. The patient will be cured by cancer. Thank you very much. As for examples, we are treating the lung cancer patient. Here we can see the tumor, okay, and also we have to draw some volume, and after drawing some volume, actually we have to draw some organometrics so that the RIX organ should be spared from the radiation, and we have to ensure the maximum dose to the tumor. And finally, the treatment plan will be finalized by radiation physicist and they will ensure the total dose. After completion of the radiation planning, we have to shift this database to the machine room. Technologies in this institute for the radiation treatment. Thank you very much. Then the radiation physicist will plan for final dosimetric evolution. Here we can see the multi-dimensional pictures of a tumor, and from the different view. Finally, we actually can see the tumor from the 3D images. This is just like the patient body organ images, and we can see different dose distribution here, and these dose distributions we can ensure that the tumor will get maximum dose and the normal structures can be spared from radiation. This is highly restricted area. Here we have lots of radiation machine, and there is chance of radiation scattering also. So this area is very restriction. We need to take permissions from the authority to enter this restricted area, and in this area now we are going to observe our radiation treatment system. Now we are entering into the through-beam liner machine. Before entering, we have to pass through that heavily built door. this dose is made up of some shielding materials so that the unusual dose or the dose inside the room cannot come out through the room. Just come. And this is the corridor system. This is the this wall is not normally built. This is known as the maze because the inside this wall there is meshing so that the radiations cannot come out through this wall. This wall is specially made. This wall is known as the maze. Okay, just come. We are okay. Now you can see the lots of immobilization devices and our two-beam liner systems, and there is a patient switch in which the patient will get radiation therapy. So this is suffering from the brain tumor. So there is immobilization device already set up, which also already you have seen into our treatment planning systems and also in our CT simulation system. This is the real-time patient. The patient will directly get radiation therapy from that two-beam system. Okay? Okay?
So, as we saw during the CT scan time, so there is a marker here. So this marker already should be matched with this point. Otherwise, the treatment will not be precisely given. So for this, we have to maintain some special procedures here. So that is after planning from the TPS. This machine is going to treat. So after fixation and after all the thing is matched, then we can go for the treatment. Okay. So before treatment, we have a special type of facilities to online verification system. Okay. So after making this, if during the treatment or before the treatment, if patient is shaking or tilted or moving somewhere else, then this online verification system tracks this movement. So this difference from the real distance to the displacement distance, this online verification system will correct it. So unless it is a 0 millimeter accuracy, so this is the special beauty of this accelerator. It will correct sub-millimeter. Okay, so that's why it is called the linear accelerator, and it is very high-tech machine. So there are a few numbers of machine in our country. So fortunately, we have this types of machine.
And this is known as the actually head or gantry of the machine. The gantry can rotate the 360 degree. You will see that the gantry can rotate the 360 degree so that anywhere tumor anywhere inside the body, we can treat the tumor from any direction. Already I have described the beam direction so that we can give the beam also from the 90 degree angle, also from 0 degree to 70 degree, any degree, any side of the treatment. We can this device is known as the couch. We can also move the couch, especially whenever we have to give radiations from the different angle systems. Can you just the rotation of the couch? Here, especially in case of the brain tumor, sometimes couch rotation is necessary, because if we want to give from these sides of the radiation, couch rotation is necessary, so that the couch can rotate up to the 90 degree and the machine head can give radiations from different beam angle as required for cure of the patient. So tumor anywhere, any deep-seated tumor, we can treat this from we can treat this type of tumor from this machine. Very sophisticated machine and very dedicated machine. By these systems, we can give very precise radiotherapy and with the hope. And finally, we come to the point that what treatment should be better for the patient. So this is the completion of our radiation treatment procedure of the workshop. I think that within this short period of time it is quite impossible to observe or to understand the total process, and it will take a long time for clear understanding. This is actually tip of the iceberg, so that you can get some idea how we are treating the cancer patient in our current or existing facility. Although we have some limitations, but we have some radiation facilities which are international level, and we are using the cutting edge